Okay, so this is a 10-month child with refractory epilepsy. Okay.
I'm there.
Sure,
I'm
Dr.
there.
Yeah, go ahead.
Sorry for me. I thought it's case number 2. I didn't realize case 1. Sorry.
That's it.
So,
No problem.
so it's a 10-month-old baby, female child, who has had severe epilepsy from 2 weeks age. And I just saw her last month for the first time. And she always had left focal seizures. So left focal tonic seizures, always. Even though she has significant delay, so she has limited interaction, she has poor motor skills and no recognition of family with the peripheral spasticity, and her metabolic profile is normal, and I have sent her genetics testing. The thing was, this focal epilepsy makes me wonder if there's a dysplasia on the right side, and her EEG does show slowing of the right hemispheric rhythms. But then because the patients we have seen with refractory epilepsy, which is a focal lesion, should have significant delay. So that's odd. So I just wanted to review the MRI if there is something on the right side, any malformation I'm missing.
What is the head circumference, Dr. Vivek?
So the head size is on the 3rd centile. Yeah. So it's on the smaller side. Yeah. But then the child is just 4 kgs. So it's proportionate to the body size. So she has significant failure to thrive. So that's why I did the metabolic workup. So looks more like a DE, developmental and epileptic encephalopathy to me, but just wanted because of the focal seizures.
All right. So this is the MR at 10 months of age. So on the top panel, you can appreciate that there is some degree of cerebral volume loss, and also the myelination pattern, if you appreciate in the central white matter, and also in the posterior aspects, which is supposed to be myelinated. It demonstrates these homogeneous hyperintensities, suggestive of a delayed myelination. The posterior fossa, again, some degree of volume loss or some problems of the interfolial spaces. Brainstem does not demonstrate any abnormality. Corpus callosum is slightly thinned. There is mild degree of inferior vermin hyperplasia. No blooming on the supratemporal parenchyma except in the lateral ventricle. This tiny focus is over there in the right lateral ventricle. And on the T1 weighted sequences, again, the abnormal white matter changes do not demonstrate any rate fraction. So it is more in keeping with delayed myelination pattern. There was a doubt of a right parieto-occipital malformation. I did not appreciate any malformative pattern in the right parieto-occipital region. There might be a degree of simplified gyration which can be exacerbated by the volume loss, but no focal cortical malformation, at least what the images were provided, and I could not find any malformation over there. So at 10 months, I could probably summarize the findings as there is some degree of volume loss and some delayed myelination with hypoplasia of the corpus callosum. No significant calcification. Maybe this is a foci of hemicity in the right lateral ventricle. So we're possibly dealing with disorders of delayed myelination. Since it's a 10-month child, we cannot term it radiologically as hypomyelination, but the pattern looks like a hypomyelinating disorder. Also, given the appearance of the skull, but as you have said that it is proportional to the weight, possible microcephaly related disorders also I would think of. But given the epilepsy also, if that is a cause of the significant volume loss, if the child is having recurrent epilepsy and that is causing a volume loss and neurodegeneration. So I'm stuck with delayed myelination, cerebral atrophy, and probable simplified gyration, but very minimal or mild. So at this moment, I'll open the case for the panelists if they want to comment on any further suggestions.
I would like to make a semantic comment. You said hypoplasia of corpus callosum. I think it's a thin corpus callosum as a consequence of white matter loss. The corpus callosum is there in all parts, isn't it?
Yeah.
Yeah, I do agree. It's related to white matter loss, and we also see. Hi, Kish, how are you? I can see you now.
Well, thank you. Hello, guys.
Yeah. Yeah, I agree with you, Jürgen. It's just a semantic comment. So the corpus callosum is completely formed, but you see that is on sagittal T2 with the images is very thin, which means that there is no malformation. So it's not genetic involvement of the corpus callosum, but there has been an insult that has been involved in the white matter extensively. And it's not only the preventricular white matter, but also the central white matter. In fact, you can see the capsular component of the white matter, which is brighter than expected. And there is enlargement of the ventricles, ex vacuum enlargement of the ventricles, while the cerebellum is preserved. There is no atrophy of the cerebellum. It would be interesting knowing how is the phase, just to start with, to see, to characterize this low signal intensity on susceptibility, and to know something else about the perinatal history, correct? Jürgen, what do you think?
Yeah, so there was no history of asphyxia at birth. And, you know, with the asphyxiated child, so this semiology of always having just left focal seizures, especially from day 15, is odd, because asphyxiated patients, what happens, you see seizures in the first few days, and they don't have seizures for months, and then they present with infantile spasms. So having a very focal semiology is very odd for a perinatally asphyxiated child, even though there was no history of asphyxia. And the child had from day 50, and there's no dysmorphology. So child doesn't look different face-wise. We do see this as developmental and epileptic encephalopathy, where the seizures are not well controlled. So you have a, you know, an ongoing process of refractory epilepsy. I wonder if that contributes to the cortical atrophy and the myelination pattern, rather than we take it as a hypomyelinating disorder.
Right.
The predominant finding, yeah, is a refractory epilepsy. So maybe it's a genetic developmental and epileptic encephalopathy with these findings.
Sorry, I joined a bit late. There is a definite neuronal problem here. It's not a primary white matter or a gray matter problem. I agree with you on that. Just wanted to ask Nihaal in terms of, you know, the separation of the signal of the basal ganglia structures, and the thalami look a bit small as well. And also there's that brainstem signal change on the fifth picture on the top. Where does that go? Is that periaqueductal only, Nihaal, when you scroll the images? Or I'm just seeing some symmetric signal in the two sides. And I'm not sure what so far has been, but I guess included the usual lysosomal storage disorders, for instance, in this case. Sorry, I missed the first two slides in terms of the workup, but it doesn't look like hypoxic ischemic injury per se. And I think it's too much to explain from an axonal degeneration from an epilepsy perspective in itself.
Yeah, I agree.
So, yeah. Kshitij, do you think it's dark enough and bright enough on T1 to think of lysosomal storage, is it?
I think it should be excluded. The bright enough on T1 is always tricky, but from what I'm seeing on my screen, it looks brightish compared to the rest of the, you know, the deep gray structures. And then it is small enough on the T2s, at least the selected images that Nihaal is showing. But there is also the swelling of the globus pallidus. You know, there is a metabolic genetic overlay here which needs looking at. And then on the last picture on the axial T2, is that Nihaal showing us signal changes in the brainstem, which are around the collicular plates, just above there, those two areas on the two sides? Where exactly is that? No, above that.
I think it's you
Yeah.
mean this one? Yeah.
Yes, those areas.
Yeah, it's in the collicular plate. Yeah.
Yes. So that is telling us that this is, you know, we have to, I don't know what your workup for mitochondrials have been so far, for instance, but we're talking about a neurodegenerative condition primarily, which is neuronal in its overlay, not primary leukodystrophies. And I wouldn't label this hypomyelination either.
To see whether it's a mito, what we need now is a diffusion. Do you have a diffusion?
The diffusion is normal, Alhamdulillah. I had it, but since there was nothing on the diffusion, I didn't put it up.
Okay. If this were a mito, however, I would expect, just to keep going with the discussion started by Kish, which makes absolutely sense. I would expect more degeneration of the brainstem, and given the amount of white matter injury or white matter loss, and I don't see enough brainstem or posterior fossa volume loss, which I would expect in mito. And at the level of the upper brainstem, the axial T2 does not have any kind of nuclear degeneration, which is a must in mito when the white matter is degenerated to such an extent. I'm not ruling out a mito completely, but in my opinion, this is not a mito. And then again, I would like to understand what is that lesion on susceptibility, which matches with the thalamic necrosis seen on T1 on the right in the pulvinar, which looks lesional. For sure, this is a very early injury because you see that there is also volume loss of the cranial cavity with decreased volume of the temporal fossa, and the sphenoid wings are smaller than expected, as well as the frontal fossa. The anterior fossa is smaller than expected. So, and we have only these images, correct?
Yeah, these are the images we have.
Yeah.
What about waiting for the result of the trio, which is on the way, and perhaps consider, of course, close clinical and MR follow-up before being too speculative? This middle fossa is not really striking for me. This kind of, let's call it temporal lobe hypoplasia, is not something very special.
All right. Any comments, Dr. Vivek? Any questions? Further questions you have? Or we'll wait for the best.
Oh, thanks. Yeah, thanks.
All right.
That was useful.
All right. Yeah. All right. Thank you. Next case is from Romit. Romit, if you're here.
Yes, sir.
Yeah.
Good evening, everyone. So this is a 8-year-old boy. He had acute febrile illness associated with gastroenteritis almost 1.5 months back. And he was with conservative management. And by the time he was discharged, the parents noticed he was not able to bear weight to walk. And slowly the weakness progressed. He was not able to sit without support. Somehow he was managed as septic arthritis at a peripheral center, given IV antibiotics for 15 days. And for the last 3 weeks before presenting to me, he had developed painless loss of vision and had loss of bladder control with increasing quadriplegic spasticity. So on examination, he had severe quadriplegic spasticity. He had the preserved cremasteric reflex, no perception of light. There was no RAPDs. There was temporal pallor on the fundus examination. We did a CSF analysis that was normal, and anti-NMO was sent, which was negative. So the question was imaging differentials if we don't have a diagnosis yet. And the child actually came after 15 days of treatment again today, and there is no improvement.
Okay. Any clinical differentials, Romit? Or gastroenteritis?
We thought, yeah, with this loss of vision, quadriplegic spasticity, loss of bladder control, we thought of demyelinating illness as a possibility. Okay. Yeah.
Would you not consider flaccid myelitis given that picture?
Actually, the patient had developed spasticity.
Okay.
So
What
we have
about-
two sets of image. Sorry. Yeah. Again, go ahead.
What about speech and hearing?
So when the child initially presented at 1.5 months into the illness, he had normal speech, but now after 15 days, the speech volume has reduced, the vocabulary has reduced, but still he's cognitively relatively preserved. He's able to follow some commands, he's able to respond. The hearing is normal.
Thank you.
Okay, thank you. We have two sets of images, I think 3 weeks apart. So this is the first set of image on 22nd Feb. On the top, we have the diffusion weighted sequences. And on the diffusion, you can appreciate these hyperintense changes of restricted diffusion in the left parietal region and also some degree in the bilateral anterior frontal regions. Also involves the splenium of the corpus callosum. The crus cerebri, the cerebral peduncles also demonstrate the symmetrical changes. The white matter abnormalities and the cortical abnormalities can be appreciated on the sagittal images, frontal, temporal, and parieto-occipital regions. On the flare sequences, again, we have these slightly hyperintense changes involving the splenium of the corpus callosum, the left occipital region, temporal region, and also in the ventral aspect of the brainstem. And again, these hyperintensities in the cerebral peduncles are demonstrated. There's also some degree of volume loss. Coming to the spine images, there was this slightly hyperintense change in the central cord. I'm not sure if this is motion related or it is pathological, but on the axial images, you can appreciate that the central aspects and the transverse regions demonstrate these hyperintensities. This is the cut from the cervical cord. The post-contrast images do not demonstrate any areas of enhancement. And this is the follow-up MR done today. Again, the diffusion weighted sequences imaging abnormalities are slightly accentuated, more clearly demonstrated on the bilateral frontal regions, bilateral parietal regions, the splenium of the corpus callosum. There is progressive volume loss as compared to the prior study. Again, brainstem and cerebellar changes are demonstrated, thinning of the corpus callosum, but no enhancement of the brain parenchyma. I could not appreciate any enhancement of the optic nerves. We have this sagittal image on the cervical cord, and I'm not sure if these are true hyperintensities or not, but since it was there in the axial image on the first scan, I'd assume so there is some degree of a long segment myelopathy of the cord. So based on these changes, if you go by the morphological aspects, you can think of lesions involving the splenium of the corpus callosum. These are the different abnormalities or pathologies which can present with these changes in the brain parenchyma, especially involving the posterior aspect of the cerebral hemispheres and the splenium of the corpus callosum. If you go into the posterior fossa changes, these are the differentials I could think of, but I don't think they really match clinically. Encephalitis, if it was an acute presentation, but given that the child is not improving and it's more of a chronic clinical presentation, I think encephalitis can be ruled out. So at this moment, I'll open the case for the panelists.
If you just go back to the first slide, there was something about the CSF, right?
It's normal.
Were the bands positive or negative?
Romit?
Sorry, we didn't send CSF polyclonal bands for this child.
Might be worth adding if this were an example. It looks like a post-infectious phenomenon. An organism was not really isolated for the gastroenteritis, right?
They didn't send any. I did send a CSF PCR that was normal.
And anything in the stools like enterovirus or other things?
Usually they don't do it here, unfortunately, but the child gastroenteritis part did improve in 5 days, but no, the organism we couldn't.
Which treatment did you use?
So it was managed peripherally for gastroenteritis. It was conservative management of some IV fluid, zinc, and ORS. That's it. The child did receive aminoglycosides and vancomycin for possible septic arthritis. This was the management done at some peripheral center because of the inability to walk. Somehow they treated it like septic arthritis.
Yeah, in a case like this, we always treat patients with high dose steroids no matter what, because there is always a parainfectious component. This is a case of ADM.
So I did treat this child with 5 days of pulse steroids after the child presented in 1.5 months into the illness. But at 15 days follow-up post steroids, there has been no improvement.
Yeah, but this looks like a case of ADM in my opinion. Acute disseminated encephalomyelitis. Looks like a parainfectious encephalitis, as Keisha said. I agree completely with him, and I support this diagnosis because acute disseminated encephalomyelitis has these features with the involvement of the middle cerebellar peduncles. As you have shown beautifully in your differential diagnosis panel, which was really well done. Congratulations. The involvement of the corpus callosum has a broad differential diagnosis as well as the bilateral. In the Bechet, for example, middle cerebellar peduncle and the reversible involvement of the corpus callosum is seen in the mild encephalopathy in children, has been described for the first time in mild encephalopathy. But now we know that the spectrum is much wider. But in this case, it's not the classical involvement of mild encephalopathy. This is rather a diffuse encephalopathy, because the reversible involvement of the corpus callosum is focal. This is diffuse involvement of the spleen, not focal. And it's diffuse because it's a disease involving the entire brain. And now we see an epiphenomenon, which is scattered involvement at different levels of the gray and white matter. But in reality, at the follow-up, you see that there is diffuse volume loss, because this is a disease involving the entire brain. So the patient had a CNS encephalitis followed by a parainfectious phenomenon, and we don't know which is, because many times, even when we send out an autoimmune panel, we don't have a final. So we probably will never know, but you can see that at the end we have a sulcal atrophy, which is very much evident. So my opinion, and of course I cannot support this scientifically, is that the patient had ADM, and that's what it is. I don't know if the patient had also optic neuritis or something else, but also the involvement of the cord supports an autoimmune phenomenon. And this is not a mito. This is not, even if we have described mitos over the mite overlap with the autoimmune phenomena recently in the AGNR involving the cord, but this is not a mito. This is autoimmune or parainfectious.
Just to add, what was the COVID status, if known?
So the COVID antibodies are negative, sir.
A few cases we had with the circumlinear brainstem involvement, which you have shown, Nihaal, turned out all to be demyelination. I mean, I would say around 3 cases we had in a cluster. Yeah, that kind of appearance, they all were demyelinating. So I think, I don't know what the cost of doing bands is in the CSF, but if you're doing a CSF, it might be useful to do the bands. I don't know if what Vivek and the other neurologists in the audience.
To wear the devil's hat, I'll completely disagree with the expert panel that this is encephalomyelitis, because you really have to see the whole picture. I've never seen optic vision loss in encephalomyelitis. This is basically occipital involvement which is causing the vision loss, which is subcortical, and it is border zone. So you have diffusion restriction which is proportionate to the degree of T2 involvement. You don't see that in ADEM. ADEM, your T2 hyperintensity is much more than the diffusion restriction, and it's not happening here. It's more of cytotoxic edema. And this is not how encephalomyelitis presents. You don't get optic nerve, you don't get vision loss that often, and you get flaccid quadriparesis. You don't get spastic quadriparesis so early. So this is just not matching with it. And I think for me, one thing which we see here, it's very odd, gas-geyser syndrome. So what happens in that? Children at 8 to 9 years age in India, they often close the door and take a bath in a gas geyser. And that causes carbon monoxide poisoning, leading to vision loss. So you have to take that history. You have to take that history because this is so typical of that phenomena. Second, you should do his retrovirus status. And third, SSPE always comes in a differential wherever you have a patient who comes like this. This doesn't look like demyelinating disorder at all.
So I wasn't sure that the diffusion was actually restricted. Did you show the ADCs, Nihaal? Yeah, only in those areas. Demyelination can reduce the diffusion in the acute setting. That's not a surprise.
It does, but not to the degree here,
Not
but this is after 3 weeks, so it's still showing restricted diffusion.
Yeah.
So
But
that was another. Sorry.
What was the blood pressure? Blood pressure, was it high or normal?
Yes, it was normal, sir. I thought of press initially, but for 1.5 months going on with normal blood pressures. So.
See, as a neurologist, this just doesn't look like an encephalomyelitis or a EDM-like disorder to me. I'll just be like, people would have their own comments, but to me, this is something, because there's so much of diffusion restriction, which is not like EDM.
I may say something. I deeply respect your experience as a new pediatric neurologist, and I think that your experience is great, and it's not comparable to my experience as a pediatric neuroradiologist, particularly because I'm only looking at the images. So I think that your experience is far superior to my experience. I'm only expressing my gut feeling by looking at the images, which is much more superficial as compared to your experience. I'm based on this, which is only my humble opinion from far away from the United States. I would just only suggest to consider this, just because I've seen tens of cases of ADM with the final diagnosis of ADM based on the international criteria of ADM, including spastic quadriparesis in children, with this same picture on MRI, including restricted diffusion. And having said that, I deeply respect your opinion.
Another doubt I had is, considering it's a demyelinating or an autoimmune phenomena, do we consider the possibility that the MRI changes will worsen after pulse steroids? It's a 15 days interval scan, and the changes seem to have progressed actually.
Yes, they can worsen, but we haven't proven demyelination yet. You need to do the bands if you have to, right?
Sure.
What do you think, Nihaal? What do you think, Nihaal?
It doesn't look like the presence of the restricted diffusion over this is almost like a 3-month period. So the child presented 1.5 months after the initial clinical presentation. So acute demyelination, unless he has relapsed and that is causing this thing, I wouldn't consider it, but I would still look. I don't know if you need to do spectroscopy or not to see if there's any this is a diffuse neoplastic lesion or slightly unusual, but still.
One thing I'll do is homocysteine. Homocysteine should be done. I hope it's not high. So, because that can present similarly. And Nihaal, have you seen gas-geyser syndrome? Have you seen that? The MRI?
No, I've not seen. Yeah, but they are more cortical involvement, I guess, rather than the white matter. But yeah, they can present posterior predominant cortical involvement is what I think.
And if you see the first image, the top first image, it looks a very border zone sort of infarct, the first one. Yeah. The top left first. Yeah. So there, and so that's very, border zone both places, anteriorly and posteriorly. very
Yeah, but the
hypotensive.
posterior fossa involvement is slightly abnormal there for border zone
But that
lesion.
one looks very.
Yeah. Anything to add again, or any other comments? Dr. Lokesh or Dr. Avita, anyone? Yeah.
Question is, what are the next steps?
I think we had enough discussion on this one. Mainly, I think what Vivek's point is the neurological disability what it has produced is very, very unusual for a demyelinating illness. Whatever the severe, even the NMO spectrum disorders, after first there will be some degree of improvement. It will not lead on to such long-term sequelae after one event. So for that clinical course is unusual for a demyelinating, but what it would be is definitely we requires further evaluation. So I think we will move on to the next case then.
Just one thing to add, apart from demyelination, when we think about post-infectious, para-infectious, immune-mediated phenomenon, it's not always demyelination.
Yeah.
Apart from giving the steroids, would you have done plex and things? Or the question was, would you have plexed the patient?
Romit?
No, sir. I don't have the facility for plasmapheresis. So we only give IV steroids, pulse steroids here.
Okay. In the want of time, we'll move on to our next case. Case number 3 is from Dr. Juhi. If Dr. Juhi are here, you can present the case.
Good evening, everyone. Just a small thing. I work at SMS Medical College, Jaipur, and not at Amritsar. So I present this case of a newborn who presented to us at day 23 of life. And there were non-specific signs and symptoms of fever, encephalopathy, poor oral acceptance. And in a screening ultrasound cranium, we found that there were abscess-like lesions. And when we went ahead with the MRI, it confirmed that there were multiple abscesses, cerebral abscesses. And when we did the CSF, that was normal. And we empirically started the child on antibacterials, repeated the ultrasound, but there was no decrease in the size, so added antifungals as well. And then when we repeated the MRI after almost 6 weeks of antibacterials as well as antifungals, the lesions persisted. So then we went ahead with the neurosurgical drainage, sent for KOH mount, fungal culture, bacterial culture, which none of them revealed anything. All of them was negative. So now we are sort of at a fix that what could be the etiology in terms of organism. We tried doing a PCR based testing, but then now the abscesses are no more drainable as per radiologist. So we cannot drain them again. And we do not have the past samples. So if we can get a clue based on ADC or projections in the cavity based on bacteria versus a fungi.
Okay. So here are the initial images. On top, we have the diffusion, and you can appreciate the area of restricted diffusion in the central white matter periventricular regions involving the frontal lobes, the parietal lobes on the right side, and also the left occipital lobes. They are peripheral area of restricted diffusion, and also some central areas of restricted diffusion in the left occipital lesion. On the FLAIR images, you can appreciate that there is a white edema in the white matter, and also these lesions presented, multifocal lesions in the bilateral cerebral hemispheres. And on the T2s, you can also, there are some areas of internal hypointensities within these lesions. But overall, a hyperintense cerebral parenchyma with multifocal lesions on the T2-weighted sequences. And these are the coronal images. And again, you can appreciate these internal projections within these lesions in the brain. And on post-contrast images, we have these peripheral enhancing lesions, multiple peripheral enhancing lesions in the bilateral cerebral hemispheres, and also some small lesion in the posterior fossa. So this is 20 days later, And as you can see that the lesions have now, the capsule is now more well formed as compared to the prior study, but they again demonstrate this restricted diffusion. There's more central areas of restricted diffusion as compared to the prior study. Probable development of pus. The flare images demonstrate hypointense changes, and also the T2 weighted sequences now have heterogeneous appearance with isointensities and hypointensities within the lesions in the brain parenchyma. This is non-contrast T1 that demonstrates T1 hyperintensity of the capsule, and on the post-contrast images you have these peripheral enhancing lesions. Spectroscopy, I'm not sure which TE was done, but it looks like a short TE. Demonstrates short or intermediate TE demonstrates elevated lipid peak with a lactate peak. The rest of the main peaks are reduced in height. I don't appreciate any peaks at 3.6 or 3.8, which can be seen in fungal abscesses, but not sure of the TE of the spectroscopy. So this is, as Dr. Juhi stated, the follow-up lab details. Just in as radiologically as we see multifocal lesions in neonatal brain, I think of as gram-negative bacteria, which is more prevalent in the neonatal age group, presenting with these large multifocal lesions. They have these internal projections within them, more commonly seen in the gram-negative Proteus and Serratia gram-negative bacteria. Coming to the differentials, toxoplasma was asked for, but in toxoplasma, the central areas do not demonstrate the severe restricted diffusion as seen in our case. TB also can be a consideration given the lipid severely elevated lipid peak, but I'm not sure of the presentation at the neonatal age group. TB granuloma, they have more hypointense areas on the T2 weighted sequences. Fungal abscesses have internal projections, and only the internal projections demonstrate these areas of restricted diffusion. They can present with acetate peaks, inverted lactate peaks, and peaks at 3.6 to 3.8, which correlate with the Trehalose components of the fungal lesions. So these are the differentials we're considering, and I'll open the case for the panelist.
I think you've covered it all. It would be good to know, even though they didn't find an organism, what they found on the surgical sample.
So, sir, it was a field full of pus cells, and the samples sent for cultures were negative.
Was it PCR done on the pus?
No, sir. So we, because of affordability issues, we could not do PCR at that time. And now that we have raised funds, but in the current scan, it is not drainable.
Okay. Basically, the sensitivity of PCR on the CSF is quite low. Many of these situations, pus PCR, almost 90% plus positivity will be there. If you have a tissue or a pus, those kind of things. Yeah.
Okay, sir.
One important thing to say is that one of the most risky complication of multiple brain abscesses is the intraventricular opening of the abscess. If the abscess opening within the ventricular system, there is an high rate of mortality. In this case, the ventricular system has not been involved yet, fortunately. And the other question is, did you get a spine MRI? Because I suspect that the spine MRI would be positive. And the other question is are the cranial nerves of this patient intact or involved? Because I see that based on the images, post-contrast images, there is clearly electromeningitis.
So we did not obtain a spine MRI, sir, and all the cranial nerves are intact. In fact, now we are 12 weeks down the line for this child. He is still admitted with us, and he is afebrile, playful. He is now, I think, 3 months old, and with no deficits. So he's doing relatively well, but then we continue to give antibiotics, so sort of in a fix.
Okay, and the other thing is that besides the fact that this is a clear-cut case of multiple brain abscesses, The way to distinguish a brain abscess from multiple intracranial metastases, which is not the case, is to evaluate and to assess the integrity of the perivascular spaces. So in brain abscesses, the integrity of the perivascular spaces can be identified. And at the top right of this image, you can see that these tiny filaments within the main lesion on the left nearby the ventricles represent the perivascular spaces which are intact. And in brain tumor, you would not see the integrity of the perivascular spaces. And if you add the susceptibility weighted images, you would see also the double rim effect, which is typical of a brain abscess and can distinguish a brain abscess from brain tumors, which has been described very well by Mauricio Castillo on AGN. So these are ways to distinguish brain lesions of neoplastic nature from brain abscesses. But of course, this patient presented with the clinical features of CNS infection, so there is no differential.
Yeah, I
Okay,
agree.
sir.
There is no differential here. The only thing from a management perspective, and I do stray out of radiology, is if the markers are down and the child is doing well, why don't you stop the antibiotics and reassess clinically? Because the radiology, you're going to have cystic damage in the brain. And if they do deteriorate later on, you can repeat the imaging to see where the baseline is again. But if your question is when to stop the treatment, then I think you should be clinically led and not by radiology in this case.
Right, sir. That's the plan we have now. Thank you.
So
Thank you,
Julie,
sir.
I cannot help but sympathize with you because this is the situation we often end up in often. But I think your confusion here, if I'm correct, is whether this is bacterial or this is fungal. So have you treated fungal or not? You're not missing, is that right?
Yes, sir. We are treating for fungal right from the beginning, and we are giving both voriconazole as well as amphobi. So we are giving dual antifungal therapy.
Because the best, see, for fungal, it's so difficult always to rule out. But if one can tap the fluid from there, one of them, and you can send for beta-D-glucan. So that's very sensitive, at least to tell you if this is a fungal infection or not. Because if it is normal, that means it's not a fungal infection. And in the blood, you can do galactomannan, which can tell you if this is aspergillus or not. So these two things, if it is possible, at least the blood galactomannan can be done.
Yes,
So
sir.
you
We
know
did
that.
both. We did both,
Yeah.
sir. So beta-D-glucan was negative, and galactomannan was raised, but galactomannan can be false positive
Yeah.
in multiple situations. Even if you give TAS and all, it can be positive. So that was borderline positive.
Borderline positive, because in aspergillus often it's significantly raised. The only reason I said that because in the GRE image, I thought there was some hypointense lesion, which might suggest it could be an angiocentric lesion. Just that, but that might. I'm just a neurologist and not a radiologist. Yeah, the first image, Nihaal, the one before that, in the GRE.
There's no GRE.
This is
No
Dr.
GRE.
So these are
Rashmita. I agree with Dr. Kish because I've treated a couple of children like this. We've had Citrobacter growing from blood cultures, which can cause these big abscesses, and they're quite responsive to antibiotics. So if you're given a long course of antibiotics for 6 weeks and the child is clinically well, it might be an idea to stop and see what happens. So I completely agree with that. We think we gave 6 to 8 weeks of antibiotics, and the child is actually, I've been following them up for the last 2 years, and they're doing quite well. Just some epilepsy which is well treated with medication. So you don't know how this resolves over time. Though you have these big things in the brain, the children, I don't know, they seem to do well. At least the child I have is doing quite well.
Yes, Rashmi, and I'm glad you brought up this slide as well. Serratia, Citrobacter, Neisseria is the other thing that we have seen a lot more in the neonatal brain abscesses. You will have a problem with cysts and the dynamicity of the cyst with the ventricles going up and down. But at this point, if the child is well, you should stop. And if they had a fungal infection, they wouldn't be so well and happily playing around. You would be thinking about underlying SCIDs and other immunodeficiencies driving that process.
I have a heroic or stupid question or remark. I mean, these are large abscesses still. With ultrasound guidance, it would not be difficult to do aspiration of some of them to reduce the pus. There is a Latin word ubi pus, ibi evacua. And maybe then you can do additional analysis of the content.
See, in older kids, we can do that. In newborn babies, it's very tricky because they will not tolerate these procedures very well. And so I have seen that for newborn babies, if you give long course of antibiotics, though you feel like there is a cyst, it resolves and they get better. So unless they have fever again and all that after stopping, I think I'd be reluctant to do any neurosurgical procedures on newborn babies.
But this baby is now 3 months old. Or am I wrong?
Yes, sir.
You're right. You're absolutely right. But the problem has started from birth, right? So, yeah.
I agree with Rashmi. I don't think you will find much. These are cystic spaces now. Stop the antibiotics, reassess clinically. You will have some problems with cysts coming up later on. You can monitor with ultrasound and just watch the space, because the white matter is going to get dissected with these cyst formations. It's a typical picture with these organisms, and you won't find this confirmation easily in any of the samples now. Yet even if you did, I think you've treated enough, right?
Right, sir. Right. I agree.
So, Juhi, in these cases, of course, yeah, because often we get patients at 1 year, 1.5 year age is when they've already been treated at few months age, and the family doctors raise their hands because they've done enough for weeks. So most of these children, though, they come with diplegia, so a lot of white matter loss related spasticity. So I think you will definitely counsel for that, because these children cognitively are really well, but they are left with a cerebral palsy, especially a diplegic or quadriplegic CP is a very significant possibility because of the white matter loss. But you cannot do much more than what you have already done.
Okay, right, sir. Thank you.
Okay, thank you. We'll move on to our next case. Again from Dr. Juhi. Again, sorry for the association of Amritsar. You can go ahead with the case.
Okay, so this child presented to us at 8 months of age with developmental delay, and on examination we found some dystonias, and this is a picture of the child wherein we can see the hair was sparse and hypopigmented. So when they came to us, they already had a scan which showed some basal ganglia diffusion restriction, and based on clinical suspicion, we kept biotinidase, glutaric aciduria, Menkes as differentials. But on repeating a scan at presentation, that was around at 10 months, I felt that the vessels are quite tortuous. So I also did a hair microscopy, and I felt that it was pili torti, but the dermatology repeated it again. And they said they examined around 10 of samples and they could not see any pili torti. Nevertheless, based on clinical and radiological suspicion, we went ahead with the next generation sequencing, which revealed a ATP7A variant, but that was variant of uncertain significance. So I reviewed the case, and I discussed, and I still feel that the imaging pattern does fit into Menkes. So I wanted to discuss, because they are expecting a second child now, and we need to go ahead with the chorionic villus sampling in this case.
All right. So the first images, these are from the film, so they are slightly distorted. I took out only the T2 weighted sequences. These are the best images I could get. You can see there is some white matter hyperintensities in the bilateral cerebral hemispheres. The basal ganglia are slightly hyperintense for a 7-month child. There is some tortuosity of the vessel on the right side over here, and also some cerebellar atrophy with possible hyperintense cerebellar parenchymal changes. But the images are not very clear and slightly pixelated. We'll move on to the follow-up scan. So correction, this is at 10 months. As you can see that there is a bilateral subdural collections or enlargement of the pericerebral space in the anterior and lateral convexities, some degree of volume loss in the parenchyma. And you can appreciate the tortuosity of the vessels in the pericallosal regions and also in the prepontine supracellular region. This is the diffusion weighted sequence. I did not have an ADC, but I'm not able to appreciate the eye diffusion weighted sequences, especially with the lack of the ADC. Again, there is cerebellar volume loss and possible hyperintense changes in the cerebellum. But so overall, I would say that a degree of progressive volume loss, development of bilateral subdural collections, some degree of hyperintensity in the basal ganglia and tortuosity of the vessels would fit into possibility of a Menkes disease based on also the clinical presentation.
I'll agree with you though. What about the head size?
Head size is large in this case, sir. So at the first visit, when we saw macrocephaly and basal ganglia changes in the first scan, we kept glutaric aciduria as the admitting diagnosis. And that it was winter time, we could not see the hair in OPD. On the admission, after admission in the ward, we could examine the hair, and then we kept Menkes as a possibility.
I would agree. And the predominant temporal changes, as you see with the white matter change there as well, Nihaal, you will agree, would be consistent with the Menkes diagnosis.
Yeah, actually on the first scan itself, there is some tortuosity. You see here the vessel on the left, the temporal fossa demonstrates tortuosity, but the image is not clear. I would probably would have raised it on the first scan itself.
Yeah, I concur with Kishit Mankad. And I would like to highlight the fact that in our papers and books, this diagnosis is always in the differential consideration with abusive head trauma, because in chronic abusive head trauma there is a diffuse volume loss and subdural effusion, but of course the differences are clear from this beautiful panel that you are showing right now, where you can see also the parenchymal damage, the deposition of hemosiderin in the dependent portions by gravity, and in of course Menkes there is no evidence of turn bridging veins.
Dr. Jui, there's a question of cutis laxa from the audience. Was that present in the chat?
So in the admission, we did not feel that, but now the child has come for a follow-up with the report, which is around at 10 months. So we do feel that there is laxity of skin.
Okay. So everything fits into Menkes.
Yes, it seems like that.
Yeah.
All
Okay.
right. Thank you.
So our next case is from Dr. Lokesh. Is one of the fellows there, or I will just present the case in amount of time. Geeta, do you want to present the case, or Dashrath? Okay, I'll go ahead. So this is a 12-year.
It's a 12-year-old male child, sir, already treated for T-cell ALL on remission, sir. He was treated with the 6-mercaptopurine, methotrexate, and dexamethasone. So for the last 1 year, he is on this treatment. Now he is in complete remission. Bone marrow biopsy and peripheral smear was in remission. New complaints were gradual left eye vision loss and left eye ptosis, which developed over a 1 month period. On examination, child had left incomplete third nerve palsy in the form of ptosis and restriction of elevation, and left sixth nerve palsy, and right side element facial palsy is there, and no other neurological deficits.
Okay. So we have 2 sets of imaging. This was done 1 month back, and over here you can appreciate areas of restricted diffusion involving the bilateral optic nerves, more predominant on the left optic nerve. Also, you can appreciate on the T280 sequences, there is heterogeneous hyperintensity and edematous changes of the left optic nerve. No parenchymal abnormality on the flare sequences. There is some degree of volume loss. Also, on post-contrast image, you can appreciate there is enhancement of the bilateral optic nerves. The left optic nerve is more bulky as compared to the right. It is extending up to the optic chiasm. Again, on the coronal images, the left optic nerve you can see is more bulky, and there was some enhancement of the facial nerves in the bilateral cerebral pontine angles on both sides. This is the follow-up scan done 1 month later. Again, there is some degree of enhancement and thickening of the left optic nerve and also the proximal segments of the right optic nerve. The pituitary gland demonstrated normal appearance, but there is some enhancement of the pituitary stalk, and overall progressive volume loss was seen in the brain parenchyma. At the time of the scan, Dr. Mankad had put this tweet out, demonstrating findings of optic nerve involvement in leukemic infiltration. And these are also cases from literature which demonstrate changes of optic nerve involvement and also involvement of the cranial nerves and the chordaequina nerves in cases of relapsing cases of leukemia. The only question I would pose to the panelists is how would one differentiate optic neuritis versus leukemic infiltration given the absence of other changes in the parenchyma and also in the extraaxial spaces?
So in this case, it was an isolated finding, right, Nihaal?
Yeah.
So you cannot. I think in the acute setting, you should still be treating this as an acute inflammatory presentation.
Yeah, clinically it was not isolated, Kish. Actually, he had progressive cranial nerve palsies, and including facial and third nerve. All those things were getting involved one after the other over a period of time.
Okay. Did we manage to see any of that on the imaging, Nihaal? I think you must have looked hard for
the facial, yes. The facial nerves are, the intracanalicular patients are enhancing, which is abnormal. But again, how to differentiate that with facial neuritis and leukemic infiltration?
Yeah, you cannot.
I think multiple cranial nerve involvements with a history of ALL. Better to be on the cautious side and think of leukemia as versus inflammation.
Yeah, and it's not just the left side, isn't it? In the prechiasmatic.
Yeah. It's there on the right side too. Yeah.
Both sides. Yeah.
Yeah.
If I may comment, when you look at the images, here we are talking about a case of leukemia, right?
Yes.
Diffusion is very sensitive to depict leukemic infiltrate in the contralateral optic nerve. We are talking about a disease that diffuse using the CSF spaces. If you look at the contralateral optic nerve head, you can see that there is subtle increased T2 signal, which may represent early leukemic infiltrate. In terms of differentiation with optic neuritis, the conglutination of the optic nerve sheath with the optic nerve is one of the way in which I differentiate acute optic neuritis from leukemic infiltrate, because usually acute optic neuritis does not show signs of infiltration of the optic nerve sheath. Here you can see that, particularly on T2 weighted images, the optic nerve is all in one with the optic nerve sheath, and is a solid structure because there are neoplastic cells creating a unique structure. And the other finding that usually seen in leukemia is that there is mild thickening of the posterior sclera because the leukemic infiltrate goes underlying the retina, and this is why we can differentiate this from acute optic neuritis. Besides the fact that here you show also the involvement of the internal autoricanal, which is obviously not present in other disorders. In terms of differential diagnosis, I don't know if you have a panel here.
No, I don't have a panel. This is just a literature review of 6 cases with leukemic infiltrations, and they try to differentiate optic neuritis from leukemic infiltrations. And
right. Right. We know now that in Guillain-Barré syndrome, we see bilateral optic nerve involvement with enhancement and thickening of the optic nerves. We see that in mitochondrial cytopathies and in SIRF1 mutation, we have optic nerve enhancement and thickening bilaterally, and we have multiple cranial nerve enhancement. We see, and we published the enhancement and the optic nerve thickening in Krabbe disease associated with enhancement of the cauda-equina roots. So the spectrum of the differential considerations in the setting of enhancement of the cranial nerves and the optic nerves has been expanding continuously over the recent years. The fact that there is the typical picture of plastic incubate that makes diagnosis very easy, however.
Yeah. All right. Okay, thank you. We'll move on to our next case, if that's okay. Yeah. Next case. Geeta, do you want to present, or Dashrath?
Yes.
Yes, sir.
So we
Yeah, go ahead, Geeta.
yes, sir. We have this neonate who was referred to us in view of seizures and encephalopathy, and examination wise also there was subtle dysmorphism was there, and with the coarse faces and a hypotonia was there, and there was no history of any birth asphyxia and born to consanguineous parents. But so to know the cause, like we have taken an MRI, but it was not correlating with the clinical features. So we want to know the differentials of such an MRI in the absence of the birth asphyxias.
Okay. What was the age of MRI? Day of MRI in area? It's in the neonatal period.
In the neonatal period, sir, around the 8th day, I think, sir.
Okay, okay. Do you want to describe the findings?
Multifocal cystic. There are like multifocal cystic changes are there, sir.
Okay. So diffusion, it is showing restricted diffusion. The entire white matter is demonstrating restricted diffusion more around the peripheral aspects. Also, the anterior aspect of the corpus callosum, the globus pallidus also demonstrates restricted diffusion, and also in the thalamus. The ventral brainstem also demonstrates these areas of restricted diffusion. And on the T2-weighted sequences, as you have said, there's multifocal, but this is more confluent. So more confluent changes in the white matter, demonstrating cystic changes, and also involving the deep gray nuclei. The posterior fossa cerebellum is relatively spared. On the FLAIR images, you have this refractory appearance of the involved white matter and hyperintense changes in the deep gray nuclei. Non-contrast T1 demonstrates some areas of hyperintensities, probably presenting lamina necrosis and ischemic changes in the deep gray nuclei. No susceptibility weighted changes in the brain parenchyma. You can see that the extensive involvement of the white matter and also the corpus callosum and relative sparing of the posterior fossa structures. The vermis is probably slightly hypoplastic, but other than that, I think it's predominantly white matter abnormality with deep gray nuclei involvement. And given the absence of hypoxic ischemic injury, one must probably think of the mimics. These are not definitive, but the differences can be the hypoxic changes. Hypoxic patients clinically usually stabilize within 1 to 2 weeks, whereas the mimicas usually do not show any improvement or have progressive neurology. Caudate nucleus and globus pallidus is more commonly involved in the mimicas. Posterior fossa can have a hypoplastic appearance, but not always. Spectroscopy can help in differentiation, but I would go with the conventional imaging findings to differentiate these changes. These are again examples from literature of molybdenum cofactor deficiency, which are similar to our case. On the labs follow-up, Geeta, do we have a confirmatory diagnosis or?
Yes, sir. We have done a basic lab investigations. So we have done homocysteine and uric acid. In that, homocysteine is reduced, whereas the uric acid is normal, and we have then sent the genetics, so it is awaited.
Okay. So I would think of molybdenum cofactor deficiency based on the reduced uric acid. And open the case for any further comments.
Do you still need to pursue a genetic confirmation with that information biochemically?
Dr. Lokesh, one of the neurologist, wants to take up the question.
I think for
Sorry, sorry, Kish, come again. What is the question?
Do we need to get genetic diagnosis based on given the imaging and the lab findings?
Uric acid was normal, but only homocysteine was slightly low, but that doesn't guide us in any particular direction, because in absence of acute history and such symmetric changes, either one of the options is if you can wait and watch for the progression. If it is non-progressive, slowly improving in resource restrained setting, you can probably wait. But if you are there is a progressive neurology, definitely would like to confirm with the genetics.
Okay, if there are no further comments, I'll move on to the next case. Case 7 from Romit. Romit, please go ahead.
Yes, so this is a 16-year-old girl that presented with involuntary movement at bilateral ankle. So basically, when she used to keep the foot on the footrest in the school, she used to have this involuntary movements, and it was gradually progressive for last 4 years. And also on direct questioning, she told that she also has urinary hesitancy and urgency for the last 4 years, but non-progressive, no incontinence. On examination, she was absolutely fine except for bilateral ankle clonus, no weakness, and mild gastrocnemius spasticity, extensive plantar response, and mild vibration loss in bilateral lower limb still ankle.
Yeah, and the vitamin B12 was normal. CSF analysis.
Considering posterior column sensations were lost, I did a vitamin B12 also, and CSF was normal, and we did an MRI.
Okay. So here we have the MR spine images. And on the spine images, you can appreciate there is some hyperintensity in the cervical and also the dorsal spinal cord. On the corresponding axial images, you can appreciate that there is some hyperintensity, more predominantly along the ventral aspects of the spinal cord. Posterior columns are relatively spared. I'm not sure if this is the hyperintensity is there or not, but it is more evident along the ventral aspect as compared to the dorsal aspect. And again, I think this was a follow-up MRI, if I'm not mistaken. And you can again appreciate the long segment hyperintensity of the cervical and the dorsal cord. The brain in the brain, there is volume loss, and I can only appreciate these tiny foci of hyperintensities in the centrum semioval and the periventricular white matter. The posterior fossa structures did not demonstrate any signal changes or volume loss. Optic nerves also, I could not appreciate any edematous changes. This was a non-contrast study, so it's only a long segment involvement of the spinal cord and some changes in the periventricular and white matter and the centrum semioval. Differentials, I'm not very certain of the differential. If MOG can be considered, NMO, MOG, demyelination. There is no acute history for a spinal cord infarction, which prominently involves the anterior columns. So yeah, I'm not very certain of the diagnosis, and I'll open the case for discussion.
Can I come back to the history? This is duration of 4 years, am I right? He has some problems since 4 years.
Right, sir.
Which is kind of unlikely a kind of myelitis, rather a long-standing problem, like whatever, low-grade glioma or hematoma.
Also on, I think the cord also is demonstrating some degree of reduced volume, especially the thoracic cord. So if it's a glioma or a hematoma, I think there would be cord expansion more than a normal cord or a slightly reduced caliber.
But the history of
yeah, the history is long-standing. Yeah.
And you have bladder problems, lower limb problems. This is a spinal problem until proven otherwise, as a hypothesis.
Yep.
So
Once
does
again,
adrenomyeloneuropathy presence like this? We don't see it in children often. Adrenomyeloneuropathy, cord atrophy with.
I would expect some degree of parenchymal involvement, isolated cord involvement.
Okay.
Maybe slightly unusual.
once again, did you all have
Mitochondrial. Yeah, Romit, any band testing for bands?
No, sir.
Is it very difficult to test for bands in India?
It's the financial constraints are there, so
No, but is it quite expensive to test out there?
I think it's somewhere 5,000, I think.
I think Romit, it's not that costly, is it? It's just that our thought process as Kshitij, I think we have to start doing it more often. Kshitij, I think we stop at routine CSF and then we send the NMDA, we send the MOG, but we haven't developed the habit of sending oligoclonal bands because it's not as costly as the habit. That's the thing.
I agree, Vivek. Here as well in the UK, whenever the national meeting happens, in fact, there's one happening on the 18th next week. If you all want to join, I can ask them to send you a link via the BPNA. A lot of centers actually forget to send the oligoclonal bands. They focus on the other things on the CSF. Because in cases like this, it becomes a binary point, isn't it? Whether there is or it's not, and it might help actually. Because those lesions in the brain can't just be dismissed as non-specific. In fact, if you look at the frontal horns, Nihaal, I don't think they're just those caps. I think there are lesions sitting there as well in the white matter.
Yeah, there are lesions in the periventricular regions and the centrum semiovale.
Yes.
Kish, are you referring to links of the ear sign?
No, I thought about the links when I saw those, but I don't want to call this links. I've never seen a lynx in my life, but I'll be startled by one. But I think there are quite a few white matter lesions which can't be dismissed completely. And, we can call them non-specific and leave it, but you have cord lesions and brain lesions, and I think we should work the basic things out first, right? Of course, this can turn out to be so many other things as we know, but we're excluding the right things.
If we come back to the clinical situation and the long history, if you think this is all related, I cannot think of an more or less acute or subacute infectious process. So this is something more long-standing.
But it's progressive. That's a problem, isn't it?
Is it progressive?
We should think of, when you have such lesions, the three things we always want to rule out as pediatric neurologists is biotinidase deficiency, intracellular cobalamin defect, homocysteine-related disorders, because B12 can be normal, and third is adrenomyeloneuropathy. Because I think Eugen is correct. This doesn't look like autoimmune disorder. This looks like more of a progressive spinal cord disorder, which needs more of a metabolic workup as well. That's what I feel. Yeah.
One for feedback then to the meeting, isn't it, Nihaal?
Yeah. Okay. All right. We'll move on to our next case. Romit, please give us the feedback whenever it's available.
Would you be able to easily exclude things like celiacs and Whipples, all those things that give cord signal and some nondescript white matter lesions in the brain?
I'll do that, sir, on follow-up.
Do you get Whipples in children?
Just seen 2 cases.
All right. Sure.
Next case, Dasha.
Yes, sir.
Okay, Geeta.
So this is a 3 or 4-month-old male child who presented to our PICU with 60% of the scars, and this child has a very stromy course in the form of like a severe septic shock, encephalopathy, hemodynamic instability, and on ventilatory support for almost 1 week. And his cultures were positive for various like Acinetobacter, and he has severe like thrombocytopenia requiring multiple transfusions, and also hypernatremia with deteriorating sensorium. So on the day 10 of life, he had a further neurological deterioration in the form of unequal pupils and extensor posturing, and that was the time we did an MRI. to know the extent of involvement and what is the what involvement will be seen.
So you just want to know the extent of the involvement rather than the cause of the. Is that right?
You want to even know the cause also, sir? Like what are the various causes?
So sepsis, coagulopathy, Acinetobacter, thrombocytopenia are not sufficient for diagnosis.
So, but the severity of the involvement we wanted to know.
That was the question. Okay. We move on to the MR images. We have the diffusion and the ADC sequences, and you can see the extensive multifocal involvement. There are some lesions. These are actually hemorrhagic lesions, which I'll show you on the SWA and the T2H sequences. But severe involvement of the cortex and subcortical regions, probably meningeal encephalitis going on there. Some involvement of the right caudate nucleus, and also involvement of the posterior foci and the right cerebellar hemisphere. Cytotoxic and vasogenic edema is demonstrated more. The cytotoxic edema is more along the temporal lobes and the occipital lobes, and you can also appreciate that there is there is degree of descending transcendental herniation, and the CSF spaces are not well appreciated, and also the brainstem is compressed. Better appreciated on the T2 and the SWS sequences. Again, the extent of involvement of the cerebral parenchyma on both sides, and multifocal areas of hemorrhages, macro and micro hemorrhagic foci involving the bilateral cerebral hemispheres, bilateral cerebellar hemispheres. Venography did not demonstrate any stenosis or thrombosis. You can appreciate the transcendental herniation on the sagittal images, involvement of the corpus callosum, and these large multifocal lesions in the cerebral parenchyma with some degree of meningeal or cortic encephalitic type of pattern. So based on that, one would think of the non-traumatic parenchymal lesions, and infection, as the patient is positive for infection, also has some degree of hematological disorders and sepsis. I think they can present with these micro meningitic processes, and also coagulopathy disorders can present with micro and macro hemorrhages. They can also present with multifocal necrotizing leukoencephalopathy. So based on that, the clinical information, I would say that probably they are related to the clinical findings of sepsis, coagulopathy, and infection. I think the clinical question was, can these be fungal abscesses or not? I would think that they are primarily macro and micro hemorrhages rather than lesions having hemorrhage within them, but difficult to exclude on non-contrast study. Yeah, case is open for the panelists for discussion.
Can you just go back to the history presentation, please?
You did not get an MRA. I see an MRB. Because
no, we didn't get MRI.
Can you go forward, if you don't mind, to the diffusion? You see that diffusion. You see that here we have a posterior circulation inferred. So I think that a lot of this is infectious. This may be a microorganism which elicit vasospasm, and so I believe that you are correct. That this is an hemorrhagic encephalopathy which has a component to it which is ischemic, leading to multiple hemorrhages. So these are not, of course, fungal, but there are microthrombotic events. I think that if you enlarge the susceptibility to your left, you can see tiny microdots, which are the small microdots. And these are microthrombi within the small circulations. And this is a detail, but we are focused on the big hemorrhages, right? So here there is a microthrombotic event, which is an epiphenomenon. The macro phenomenon here, macroscopic evidence, is that there are macro hemorrhages or intraparenchymal hematomas, which are related to the fact that the patient has an intravascular formation of clots. clotting due to the infection. So we have a cascade of events related to the infectious phenomenon, similar to what happens in acute necrotizing encephalomyelitis, but the acute necrotizing encephalomyelitis cases described by Bob Zimmerman all involve the basal ganglia. And so when I see cases like this, my flow chart is looking at the basal ganglia and then go to the periphery. And here we don't have the basal ganglia being involved. This is more peripheral, right? But the diffusion, as you properly showed, involves vascular territory. And so I don't know what the other panelists think, but I think that this is a brainstorm caused by a microorganism with a major vascular involvement on both the coagulation side and the vascular wall side.
When I read the history, I was impressed by the combination of sepsis and needing inotropic support. So I have imagined that this is also a kind of perfusion failure to some extent, responsible for the multifocal lesions with secondary hemorrhage, perhaps.
Yeah. Anything in the cardiac side, if this is septic emboli, for instance, in the brain?
Geeta?
No, sir. It was 2D echo. It was just a left ventricular dysfunction. That's it, sir.
Did you do a chest X-ray?
Yeah, yes, sir. Pardon?
How is it? Positive or negative? And did you do a cardiac ultrasound? And how is it? Positive or negative?
It was not adding much. It was not adding much information, sir. Actually.
The what? The cardiac ultrasound or the chest X-ray?
The cardiac ultrasound.
So no PFO, right?
Yeah.
Okay.
Okay. Thank you. To our next case, either one of Geeta or Darshat can. Darshat, you want to take over? Okay, otherwise I can present the case. So this is a 3-month female child born to third-degree consanguineous marriage. Birth weight was 3 kgs and there was no history of birth asphyxia. Had mild respiratory distress with feeding issues, hypotonia, and paucity of movements in all the limbs. On day 5, the child presented with seizures, which was controlled with Levipil. The feeding and limb movements improved after over a 1-month period. Now, at the age of 3 months, the child presented with recurrence of seizures and deteriorating sensorium for last 2 days. On examination, child had an normocephalic head with some degree of facial dysmorphism in the form of retrorachia, high arched palate, long philtrum, and sparse and thick hair. The child was encephalopathic with bifacial weakness. There was no rooting or sucking, and the child also had severe hypotonia. There was contractures in the proximal internal phalanx and distal internal phalanx joints of little fingers, and there was curling of the fingers on both sides. Muscles were flabby and the deep tendon reflex was absent, and the child was severely encephalopathic. There is some degree of bulbar dysfunction, dysmorphism, and lower motor neuron weakness, and also had a history of neonatal epilepsy. So this is the lab evaluation, which demonstrated mild elevation of blood lactate, normal CPK, and ammonia. The nerve conduction study demonstrated axonal neuropathy, and the 2D echo demonstrated mild pulmonary artery hypertension. We have the MR images at the age of 3 months. So on top we have the diffusion weighted sequences. And if you come down to the level of the globus pallidus and the subthalamic nuclei, you can appreciate these areas of symmetrical chains of restricted diffusion involving the red nuclei and the midbrain, and also the pontocerebellar fibers and the central tegmental tracts. These show corresponding areas of low signal changes on the ADC sequences. Sorry. Yeah. And on the T2 weighted sequences, the corresponding areas on the diffusion demonstrate T2 hyperintensities, the globus pallidi, the subthalamic nuclei, the brainstem, and also the central tegmental tracts. There was a tiny foci of punctate hemorrhage in the occipital horn of the right atrioventricle and possibly in the tip of the left occipital horn. These are the spectroscopy images at the long TE. This is at TE of 270. There is a tiny elevated peak. This was at the region of 3.5 to 3.56. I'm not sure the significance, but it is there and it should not be there on a long TE. So based on the imaging findings, these are the differentials which one thought of. NKH based on the involvement of the central regions of the white matter and also the brainstem, and also the peak on the long TE spectroscopy. MSUD probably less likely. Mitochondrials would also be need to rule out, especially the tRNA related disorders. ITP encephalopathy, again, they present with similar imaging findings and can have microcephaly and facial dysmorphism. We have seen cases of hypernatremia also presenting with these changes in the pyramidal tracts and the central gray matter. Bigobacterian is also a possible differential based on the involvement of the globus pallidus, the thalamus, and also the brainstem. So these are the imaging differentials, and just to check if it fits clinically, and other suggestions on the scans and the clinical presentation.
Can I enlarge the differential diagnosis? I have in mind that looking at the brainstem involvement, that similar findings have been published in a group. The abbreviation is GPI. It's kind of an anchorage system, about 10 different genes like peak N, peak A, and so on. And this would be for me also an option.
Okay. All right. Okay. Thank you.
Nihaal, of the differentials that we often use for this, you think if you went back to that and kind of tried to narrow it down based on this history, what your approach would be? I think for the residents, it will be a useful way in which we think, right?
Yeah. So I would think of NKH as the first possible differential, given the glycine peak, or at least what is supposed to be a glycine peak on a long TE, and also the involvement of the globus pallidi and the central white matter. Brainstem involvement and cerebellar involvement can also be seen. Once you move past to NKH, I think the differentials are broad. I think clinically, I think they are suspecting mitochondrial disorder. At least that is what was mentioned to me. Dr. Lokesh wants to comment anything on that.
So
Okay,
just
I don't think we have Dr. Yeah, Dr. Please.
With the history of seizures, so our papers just got published in epileptic disorders on ITPA associated DEE, and our patients have very high glycemia in the CSF, and we are sort of postulating that the similar changes to NKH happens in ITPA, and that's the reason for similar sort of the MRI changes in NKH and ITPA. Even though these patients in ITPA, it's more of the the one you have shown is classical, and this patient is slightly different. Though the seizures, the bad seizures reverse that.
Vivek, can you please share your paper? Congratulations on it being published as well.
Yeah, sure. I'll email it.
Okay, if there are no further comments, we'll wait for the follow-up. I think that case will be sent for genetics. Moving on to our next case, again from Dr. Vivek. Dr. Vivek, you want to present the case?
Yeah, so this is a very interesting 13-year-old boy who had come to me end of October last year, so 4 months back. At the time, he had a history of So he was well up to 4 months before that. So 8 months before today, he was a well child, completely normal, no previous history of any issues, and he developed progressive ataxia. So he would fall often, and he would have more of, parents said, like a drunkard gait through the day. So there was no variability to it. And then he started to have change in his voice and became dysarthric. And then they noticed over the next few months that he was not as strong on his left side as the right. So ataxia with a degree of left-sided hemiparesis, which had developed over 4 months, progressive. There was no history of any acute febrile illness or an ongoing febrile illness as part of this phenomenology. And on examination, it was more of a cerebellar disorder, which is more of a scanning speech, unsteady gait, tandem walk difficult. Again, the dysmetria was more on the left side, which was disproportionate to the degree of hemiparesis. And surprisingly, his position sense and vibration sense were also impaired, which suggested that his spinal cord must have been involved at some level, though his bowel and bladder function was intact. He did not have any history of rashes, ulcers, no history at all prior to this. This was the history he came with. And then we had the neuroimaging. This neuroimaging was already done from outside, and the child came with this MRI.
Yeah, so on the MR, you can appreciate this is the diffusion, some of the areas of restricted diffusion, multifocal lesions predominantly involving the white matter, the deep white matter, the superficial white matter, and also the juxtacortical subcortical regions. Coming down the posterior fossa, the brainstem demonstrates these focal lesions and also in these cerebellar peduncles on both sides. The corpus callosum also demonstrates involvement, especially in the body and the splenium of the corpus callosum. Post-contrast study, we have incomplete ring-like enhancement and also nodular and complete ring-like enhancing lesions. So at this moment, we are thinking of a possible vasculitis or possible demyelination, isolated syndrome, vasculitis type of inflammatory vasculitis, and then the child presented with it.
Let me. So at the time, so I got him admitted at the time in end of October, and for my thought process again was, is it a vasculitic process or a clinically isolated syndrome? And then at the time, the vasculitic workup we do, ANA, vasculitic, whatever we could do, it was all negative. But his CSF oligoclonal bands, thankfully I did that. So proteins and cells were normal, but CSF oligoclonal bands were significantly raised, 10 plus. And for me, with those near the corpus callosal lesions and no other cause found, so cryptococcal negative, tubercular negative, everything was negative. I thought, because when you have oligoclonal band and I already have the lesion, I thought time and space is fulfilled. For me, it was multiple sclerosis at the time. So I treated him with methylprednisolone and put him on oral steroids, tapering steroids with a plan to give him disease-modifying agent. So I think it's my inexperience with treating multiple sclerosis, because we don't see them that often in children, that we just think that CSF oligoclonal bands being so strongly positive is MS, which I learned now it is not always, obviously. So this child came back to me. He came for a follow-up in between, and he was doing really well. The symptoms obviously resolved with his steroids. End of January, he came to me with this severe throat pain, and he had these ulcers, oral ulcers, and there was a small lesion on his buttock at the pressure site as well. So, and with a history of fever for a week. So we thought that this is because he's immunocompromised, so he might have had an EBV infection or something similar. And lo and behold, his EBV, VC, IgM, IgG came positive. So we thought this is a bad EBV infection, for which we admitted him, or a streptococcal. So we admitted him for a month, and he had been with us for last 30 days. And his ulcers started to improve gradually. He had been on NG feeds, and now he's better, but his fever continued for the whole month. Every day he would have fever. And initially we attributed to these bad lesions. And then one of my very sharp colleague friends, dermatologist, he recently visited the child and he examined him in details. I have permission from the parents for all these photographs, so I have appropriated them. So he could see a genital ulcer. And then we had done a MON2 test, and interestingly, the MON2 was negative, and we just forgot about it. And then the dermatologist said, look, this is not positive, but this is pathology positive, because there is a small vesicular lesion which has come up because of the needle abrasion of the skin. So it's not MON2, but this you have to notice. So this is again a lesson. So if the needle goes in and if it's not MON2 positive, at least look for that red dot. So that would suggest with the oral ulcer that it could be Beckett's disease. So then we repeated his MRI. At the same time, the MRI was repeated. You know, just the time I admitted him in January end when he got unwell, I got an MRI done, which was not 6 months. Actually, it was my mistake. It was 3 months after his initial MRI, which was showing some improvement in the lesions. But for me, those lesions, if you see in the sagittal section, to me looked as if these are Dawson fingers, and I'm looking.
Finger.
Yeah. So I was fairly convinced that this is MS and we are having a superimposed infection. But with this new finding in the last few days, we think that this all might be neurobeckets.
Okay.
But again, for me, it's so it's just for the experts to have a look and see if neurobeckets or MS, what it could be. And we have sent his HLA-B51, which is only 50% sensitive. It's always a clinical diagnosis.
I'll straight away put the case for the panelists because we're running short of time.
There's something unusual about the morphology to call this MS. All these lesions have targetoid appearance, and vasculitis is the first thing that comes to the mind when you look at it. And when you opened up the case for discussion, it's a very close mimic, we know that. But if you look at all the lesions, they have this central unenhancing area, which in the context of demyelination, we expect broken rings of enhancement, but not like this. This is very atypical for MS as morphology. Bands wise, I don't know if they are matched, unmatched, and what the picture with that is, but this is not typical for multiple sclerosis and Dawson's fingers, even though the location is periventricular primarily.
They were matched, so it was significantly more in the CSF.
Yeah, I think that we are biased by the fact that there is this diagnosis of Behçet disease. I've been working in a center that was studying neuro-Behçet disease for many years. However, I do agree with Kish when he states that these lesions are not typical lesions of MS for several reasons. If you can go back to the images, please. So the rim enhancing of this lesion is too thick to represent MS lesions. They are not all distributed with the pattern of the dozen fingers. The center is too dark, as you said on T1 weighted images. And so, and the amount of vasogenic edema is too extensive. And then there is another pattern. The central pons and the involvement of the middle cerebellar peduncles is not the typical topography that we observe in multiple sclerosis. And also the periventricular involvement is not typical. So the colleague neurologist, I believe, has very good points in saying that this could be neuro-Behçet rather than MS. Neuro-Behçet, if you review the literature, has a wide spectrum of a neuroimaging presentation, and this would be a very interesting differential consideration in neuro-Behçet. I would recommend to do a total spine MRI too, not only the brain, because as you see, the cervical spine is involved. I would expect this patient to have lesion in the cord. Not only, we see that there are multiple lesions in the cord, so I would expect to have multiple lesions in the spine, and we see also that there is involvement of the cranial nerve. So the bottom line is that neuro-Behçet is in the differential, and I would consider this highly rather than purely MS.
And when I was reading through the brainstem lesions in the pons, it's very suggestive of Beckett's. Is that right? More often in Beckett's rather than in MS or
yeah, the mesoddiencephalic lesions.
Yeah, exactly. The topography, not rather than the pons lesion, because MS targets the pons and the middle cerebellar peduncles, as you see in this picture on T2, the second from the top right. But the morphology and the location is more for autoimmunity from Behçet and vasculitis related from Behçet rather than DMS. And the enhancement patterns and the morphology that we see on post-contrast images is more from Behçet rather than from MS. The rim is too thick, in my opinion. The center is too dark, as Kish said, and I believe that the support of this skin biopsy bends towards the final diagnosis that the neurologist from India is making, and I think that the proper diagnosis will be Neuro-Behçet rather than MS.
So I wanted to ask one question. Did you say the bands were matched? Because if they are matched, we are not confirming primary CNS demyelination anyways, right?
Sorry, when I meant matched, what I understood was that did we send blood and CSF? So there were no bands in blood and CSF was significantly raised. Sorry, that's probably what I understood from.
Yeah, I think it's not common, but it's possible to have this in Behçet's as well, the bands, isn't it? From what I understand, I have to check the literature on that again. But a great case all the same. I think the one time we did the bands in all our spectrum here today, I think it was actually a bit misleading if you think about it.
Right, that is a great case actually, and it's the way in which it was managed was actually fantastic. Congratulations.
Thanks.
Question, last one, if I can sneak in. And what is the overall natural history? I mean, do these recur, or what happens to the Behçet's population? I've not seen follow-up studies on this particular spectrum. Does it give you a bit of a relapse remitting pattern, for instance, or is it it won't come back once you've treated it?
Yeah. So can I answer? Can I? Yeah. So the thing is, it's my first ever case I've seen in my life. I've never seen Beckett's, so it's more of a literature search from which I'm saying, not my experience. Beckett's, Neuro-Beckett's is a bad Beckett's, so it tends to reoccur often, leaving significant disability, and often they have to give cyclophosphamide cycles. So it behaves like MS, but it is not. So, but they do go into remission longer term, but does leave you with disability. So MS is worse. To have MS is worse than having Beckett's, but it does reoccur. But again, this is just my first possible case, so I don't even have a long-term experience of dealing with it. So just by literature search. So 1/3 of Beckett's patients can have Neuro-Beckett's. That's what I realized. And so it can present. So 1/3 can present with Neuro-Beckett's disease. Then you get the history, and there's history of small ulcers in the past, and then it can reoccur often if not treated aggressively.
Thank you very much, Vivek.
All right, thank you. I have 2 more cases. Probably try and finish them in the next 5 to 10 minutes. If Sahil, you can quickly go through your case.
Yes, sir. So he's a 14.5-year-old male child, born of 4th issue of non-consanguineously married parents, with normal perinatal and developmental history with negative family history. So at 1.5 years of age, he had an episode of focal seizures, right-sided tonic-clonic seizures, and followed by which there was right-sided weakness upper limb and lower limb, right hemi weakness. And so he underwent a stroke workup, like sickling test, vasculitis workup, lipid profile, cardiolipin, and phospholipid antibodies. All were negative. So yeah, so initial MRI with MRA was done in 2008. Yeah.
Yeah, on the diffusion, I cannot appreciate any areas of infarction or ischemia. Some gliotic changes in the left parietal region and also the occipital region, but no acute abnormalities. As you have seen that there is an interrupted arch of the aorta. This is a type B variant, and also there is a tortuosity of the internal cerebral artery on the left more than the right. What we call the drooping splenium of the corpus callosum, non-specific finding. But other than that, no acute changes. Some areas of some chronic changes in the left parietal occipital region, and these vascular tortuosities in the internal cerebral artery and also the interrupted arch of aorta. Yeah, 2010. In the meanwhile, Sahil, what was the presentation?
Yes, sir. In the meanwhile, he was discharged on oxcarbamazepine and aspirin that time, and gradually over a period of 6 months, the weakness improved and he was completely normal. But again, at around 3.5 years of age, he had fever, vomiting with right-sided upper limb and lower limb weakness again. So in view of the recurrent ischemic attacks, though he was worked up, and MRI with MRA was done this time.
Yeah, again on the diffusion sequences, cannot appreciate any acute abnormalities. The tortuosity has increased, more lenticular collaterals are demonstrated, and there are also chronic changes more now in the frontal regions, the frontal and parietal regions on both sides. That is more along the watershed territories. No deep gray nuclear abnormalities. Next.
So he was then normal up till 2013, up till 6 years of age. During that time, the child was worked up for a suspecting Moya syndrome in this child. He underwent DSA examination, which was not conclusive because there was no a proper arch of aorta was not visualized on DSA. So underwent a 2D echo, and finally he was diagnosed as a case of intermittent interrupted aortic arch type B, and eventually he had a workup in 2013 again. Yeah.
Okay, so 2013, there are some areas of restricted diffusion, not very bright on the DWI, but there are some areas of low signal changes in the right frontal region. Progressive volume loss in the left cerebral hemisphere, and as you can see, the watershed territory region chronic infarcts are demonstrated on both sides. The tortuosity has increased. There is stenosis of the parietal internal cerebral arteries and also the proximal middle cerebral arteries. A slightly straightened appearance of the mid and proximal segments of the middle cerebral arteries at this point. Yeah, next.
So then, in view of the interrupted aortic arch type B, he was advised surgery, but and the risk was around 40 to 50% high risk, and so the relatives were not willing for undergoing a surgery, and then they came back and they did not go for any medications. They just continued oxcarbamazepine and aspirin, and slowly it was stopped. Eventually he was started on some Ayurvedic medication, which he continued for around 4 to 5 years, during which he had no complaint. But again in 2019, he came with the episode of fever with weakness, right-sided hemi weakness again this time during year.
Okay, so again, the diffusion sequences, they are slightly bright. I didn't have the ADC. The left frontal probably slightly better than the right. Posterior fossa, I cannot appreciate any abnormalities. Progressive volume loss in the cerebral parenchyma, left more than the right. And the tortuosity is again demonstrated. It is slightly progressive. The right-sided middle cerebral artery is is less in caliber as compared to the left. But again, tortuosity of the vessels and chronic ischemic changes. I'm not sure if this is an acute ischemic change in the left frontal region.
Yes, and yes, now he came with some very non-specific illness. He had some acute gastroenteritis, no weakness, no neurological deficit as such now. He's on aspirin and he's doing well. So we just wanted to know what were the previous MRI findings versus the current MRI finding that we have done in February 22 in this patient. Yeah.
Yeah, again, chronic changes, no restricted diffusion, chronic changes with volume loss, more on the left cerebral hemisphere. And I have the video, I'm not, yeah. So you can appreciate the tortuosity of the vessels in the basal cisterns and the interpedunculair cisterns. The left ICA is not visualized, at least up to its terminal portion. Is probably collateralization over there. Yeah, so extensive collateralization. The left ICA is not visualized. The right ICA is hypoplastic. So I would thinking of Moya-Moya association. The possible syndromic associations, I could not find any association of the interrupted aortic arch in specific with the Moya-Moya syndromes. So the interrupted aortic arch, as you have seen in our case, whereas the left subclavian artery is separated from the left common carotid artery, it is most commonly associated with DiGeorge syndrome, but I could not find any association of DiGeorge syndrome with the Moya-Moya pattern or the stenotic appearance of the vascular abnormalities in the brain. Other syndromic associations with Moya-Moya, Alagille is a common association, but it does not have the clinical features as seen in our case. So the case given to me by Astik. And you can appreciate chronic ischemic changes with these stenotic changes and tortuosity of the intracranial vessels with butterfly vertebrae, facial dysmorphism, and iron and kidney changes, which are not seen in our case. So at this moment, I'll open the case for the discussion.
I got nothing to add at the moment.
Okay.
Yeah, me neither.
All right, we'll move on to our last case. Yeah, Sahil?
Yes, sir.
Just
this is
point about the previous case. I'm sorry. At what point will you consider any revascularization? Because it looks like it's quite progressive, isn't it? What is the plan with the child after this?
so the child was advised to undergo surgery way back in 2015 for the interrupted aortic arch.
Looks like the outlook is quite grim, isn't it? This is.
Okay. Okay. We'll move on to our next case. Sahil?
Yes, sir. This child is a 1.5-year-old male child born of first issue of non-consanguineously married parents with normal perinatal and developmental history. So initially in October 2017, he had started with left-sided tonic-clonic seizures, and some private practitioner started him on syrup valproate, and after which he was completely seizure-free till 4 years, till December 21, during which he had again a similar episode, and during which the valproate was increased. But on 24th of February, the child presented to us with clusters of seizures, around 10 to 12 episodes of fever-provoked seizures. In status, he basically presented. And he was admitted, he was loaded with Levera, and finally the seizures were stopped. And as a workup protocol, his electrolytes, CBC was sent, which was completely normal. And we planned to do an MRI since it was not been done before. We planned an MRI. Yes, sir.
Yeah, on the MRI, we are on the top panel, we have the diffusion sequences. Cannot find any acute ischemic or cytotoxic edema in the diffusion weighted sequences. The T2, there is a mild degree of volume loss, but other than that, some terminal zones of myelination. no focal lesions, no malformations. Yeah, so
Yes, sir.
not very strong MR to correlate with clinically. So at that point,
So, followed by which post MRI, there was a sudden deterioration of the Glasgow Coma Scale, and there was very poor respiratory efforts, and was immediately shifted to PICU and was intubated. So in PICU, the child had continuous fever spikes. The bedside EEG, which we had put, suggestive of non-convulsive status epilepticus, and so the child received a Midas drip also. Later on, he demonstrates signs of raised ICP, fixed dilated pupils, and not very promising, developing good clinically. And CT was done, emergency CT was done.
okay, what is the time frame between the MR and the CT?
Sir, it's almost within a day, sir.
Okay.
Almost of 18 hours. The next morning it was.
Okay. Okay. And this is the CT plain study. As you can appreciate, there is diffuse cerebral edema. Sulcal spaces are effaced. The ventricles also are compressed. And you have this typical white cerebellum sign, whereas there's preservation of the cerebellum, and supratentorial parenchyma demonstrates this diffuse edematous changes. I do not have an explanation for the findings. If there is any clinical pointers which can help as to why the child has progressed so severely and so quickly over the time period of less than 1 day.
Could you please go back to the history? So one of the reasons here would be the prolonged seizures that he had, and it looks like he had a cluster that could have led to the hypoxic ischemic injury as well. A lot of that is not going to reverse, right? So no, I don't think we can have any more handles to this. Any, did you say there was infection in the background, kind of pushing this in the direction?
Yeah, fever spikes were there.
Fever spikes were there, sir, and he came to us with lots of clusters of seizures, and he was loaded with Levera, and the seizures eventually stopped. His GCS improved, and he was shifted in the step-down unit also.
Because there's swelling on the brain MRI already, isn't it, Nihaal? The process starts in the MR stage. You can see the top bits there. It's quite blurred out, everything. So there's an ongoing process. And then that leads to diffuse CT swelling as well. So the process starts here.
Okay.
But I think the etiology is unknown at this point. How old was this child? Again?
5 months, sir.
Okay, you're not worried about any strangulation and things like that, right?
No, sir, no. Good developmental history, no issues, nothing there.
I don't see anything in the back of the neck for any manual pressure around there.
No.
Because this child had a metabolic profile was also done in this child. There was sudden deterioration.
Yeah,
that was also normal. So you're thinking it could be either such a rapid deterioration of the child. When he was initially admitted, his GCS was good. He was shifted to step down, and then after that, immediately in PICU, and then very rapid deterioration, and finally he succumbed. But yeah.
So sudden unexplained death can have many etiologies, and as the last case of the day, I think we can endlessly discuss this, and Eugen will have a point of view as well about these children, where in the West, we will be very suspicious about the cause of death when it's unexplained, and all you have is anoxic seizures at presentation with plus minus sepsis driving it in the background.
Very difficult situation. But I mean, the history is key here. How was the condition of the child before the MR and so on? I'm not want to be too speculative, because this could have a legal consequence as well. But the absolute deterioration after that intervention makes me a little bit suspicious that this was finally also responsible for that breakdown or failure.
There is a
This is like a drowning accident, you know.
Exactly.
Yeah.
Am I audible?
Yeah, Dr. Kavita, go ahead.
Yeah, good evening, everyone. Sorry, I was trying to unmute in between, but was not able to. So this child actually was like a known epilepsy and had relatively a very quiet course till, of course, I mean, for a few months. And then when he came here, he was having a few seizures, and probably the fever was because of the ongoing seizures. So it did not start with the fever and then went into seizures. We are still not sure whether it was a kind of encephalitis or what, but at least the MRI did not show any evidence of encephalitis in the initial phase. And then, of course, once he went into that secondary phase, so initially he had a few seizures, they got easily controlled. He was shifted into the step-down unit. Then again, he started having, depression of sensorium and respiratory abnormalities. And then when we did the continuous EEG, we found that a non-convulsive status was going on. He was having electrical seizures. And then when the CT was done, this was showing, this fulminant cerebral edema. So we read through some case reports that you can have such, because even if it is hypoxic, usually it will either cause a very laminar kind of necrosis or a basal ganglia damage. None of it which is present here. There's only edema. So that's what then we searched the literature and we found that there is an entity called fulminant cerebral edema. And when I discussed with my colleagues, they also said that we have seen a few such cases where there is sudden deterioration. There may be an element of encephalitis. Of course, in this child, we could not do a CSF. But I mean, to explain this only on the basis of status is very difficult.
No, Dr. Kavita, they are suggesting that something else, which has.
Yeah. So that's what.
Yeah.
No drowning or nothing of that kind of was there. There was no any kind of suspicious.
Was there liver dysfunction?
No.
It's just
Child
because
was
if
actually.
Oh, sir.
Yeah. So he came like a routine status with a few breakthrough seizures, and then was actually controlled, shifted out, and then he secondarily worsened.
Yeah. So because Alpers disease, one can think of a valproate associated, and then suddenly child deteriorates. So Kavita, we had two patients, not this age group, but around between 7 to 10, similar history, died brain dead in 24 hours, acute fulminant edema, and surprisingly had very high TPO antibodies. And we have tried to publish it, and it has been rejected everywhere because nobody believes that it is related to Hashimoto. But it has happened to two of my patients. They come and within 24 hours, seizures and death, brain death. And this is the CT they have, and very high TPO antibodies. So whether the TPO is telling us that there is some sort of a cytokine storm or autoimmune phenomena, that's what it is. But I've not been able to convince people to agree to it.
Yeah, so one of the theories that they have given for this fulminant cerebral edema is a cytokine storm, because we are not finding any kind of lesions which should lead to coning and all. There's nothing like any focal lesions or anything here. So one of the theories behind it is cytokine storm. But I mean, we do see such fulminant presentation in encephalitis. Like Chandipura virus is known to cause death within hours with a very fulminant cerebral edema. But here there was no setting of encephalitis actually. Known case of epilepsy coming with few seizures, then getting controlled and then secondarily deteriorating. But of course, we did not look at anti-TPO antibodies or even Golgi mutation for that matter.
And I don't think TPO is this child would have Hashimoto's, but it's just the TPO suggests that there is a significant reaction going on. So those two patients had thousands of TPO antibodies, more than 1,000 in both of them. They came within a month's duration. And we just did TPO antibodies in the second one because it was positive in the first one, and same acute fulminant cerebral edema, 24 hours brain dead. But they were older children. One was 7 and one was 13. So yours is quite young. So I don't know.
This child is quite young, yeah. But we have had such kids. I mean, when I thought about it, but we have not really registered them properly. But we have had such cases during the encephalitis season like this. They may have just few hyperintensities in the MRI, but here the MRI was completely normal when he came.
It wasn't normal, the MRI.
It wasn't normal. Yeah. There are some.
there is a lot of white matter swelling there, and you can see even on a diffusion, you're beginning to see, that would have been reduced on ADC values. It's too much on that MR.
Okay. So it's possible that it may have been some seizure-induced edema only then.
It can be a bad, long seizures can actually lead to this anyways. We know that as an etiology. And then if you say he's had seizures and epilepsy before, then that is also possible. Don't know what his neurotransmitters are doing. When we have had this situation, we've thought about infection, but it's very hard to prove it later on.
Yeah, and we could not do a CSF also in this child.
He's got diffuse brain involvement. The cerebellum is maybe just relatively spared, but it's not totally spared. Even the cerebellum is involved, you see. And I think from what my basic learning is, when you have a diffuse involvement like that, we think encephalitis.
Yeah. One thing I would recommend is to have a review of the images from image number 1 to the last sequence obtained during the examination to see whether it was an issue related to the intubation, whether the brain was properly perfusing during the intubation, during the MRI process, because the other issue that I may think about was that the patient was not being perfused properly during the MRI scan, as not being properly perfused may have led to the finding that Keisha is noting now. And so in such a case, since the MRI examination lasts 45 minutes, and usually the diffusion weighted image is the most sensitive sequence to stroke or hypoxic ischemic injury, but is obtained first, the last sequence would already show other findings, because it's already at minute number 40 compared to baseline, which is minute number 5. What I mean, if it's an ongoing process related to the intubation, so iatrogenic, and not to the seizure, which has
we'll
not.
review that. Yeah.
Hmm?
We'll go back and see that.
Because we have not been discussed an iatrogenic event. The patient was awake and well when was intubated. Otherwise, it would not have been intubated. Correct?
Mm-hmm. We'll just go into the details and get back.
Meaning, we have to consider also iatrogenic events, unfortunately.
Oh, okay. Thank you.
Okay, thank you.
Nihaal,
Apologies for going over time, but yeah, I think that should be our last case. We'll have a look at this case in the next meeting from Dr. Vivek. See ya.